This presentation is on deformities and injuries of the phalanges, also known as the fingers. I'll give you a heads up that this presentation is a little bit longer, so just be ready for that. You don't necessarily have to remember anatomy, as I'll have a lot of visual aids in this presentation to help you out. One thing I will have you take a note of is on the bottom right picture. You'll take note of the A3 pulley, which is at the proximal interphalangeal joint, and the A4 pulley, which is on the middle phalanx. Starting off with jersey finger, it is a flexor digitorum profundus rupture. That muscle is also abbreviated as FDP, also known as rugby finger. And FDP, as a matter of fact, is attached to the distal phalanx, which means that FDP is also the only muscle that flexes the FDP. While on the other hand, we have the flexor digitorum superficialis, which is FDS. That attaches to the middle phalanx, which is more so for PIP or proximal interphalangeal joint flexion. Type 1 jersey finger is a severe avulsion. The tendon retracts into the palm and the blood supply is severely compromised. And Type 2, the tendon retracts but remains at the A3 pulley, which in that picture was the proximal interphalangeal joint. Type 3, the tendon retracts and both the tendon and the fracture fragment remain at the A4 pulley, which is on the middle phalanx. Type 4 is similar to Type 1. It is a fracture and the tendon is avulsed from the bony fragment, and the tendon can retract into the palm. The most common mechanism of injury is grabbing a jersey, so forced extension of a flexed digital finger, such as in football here. Pain, swelling, tenderness on the volar aspect of the finger is a common sign and symptom. While the athlete is resting or relaxed, the injured finger does remain in extension. Since that flexor tendon is ruptured, the extensor tendon is pulling it back in extension. This results in no dip flexion, since there's no no tendons to flex the distal interphalangeal joint, and the athlete will also experience a painful grip. Playing in contact sports and participation in sports with frequent grasping is a predisposing factor to jersey finger. Also, running at high speeds while grasping, whether if it's a ball or a jersey, is also a predisposing factor, as it can cause a mechanism. I have the flexor digitorum profundus and superficialis tests. Those are more so for manual muscle testing. For this injury, the FDP test would be more commonly used, as we can still evaluate the superficialis. However, in this case, we'll more than likely be evaluating the FDP.
In summary, when I want to examine the FDP, I would say to the patient, I would immobilize the middle phalanx and say to the patient, can you bend the tip of the finger down? Good, that's fine. And then to examine the FDS, I'd hold all the other fingers out straight and say, again, can you bend that finger down for me? There are some exceptions to that. The little finger doesn't always have an independent FDS. So if I was to hold the FDP for all the other fingers and ask the patient to bend down at the little finger, this patient does have an FDS to the little finger. However, some people, myself included, if I hold my fingers down, I can't bend at the proximal interphalangeal joint of my little finger. There are two possible explanations for this.
If you want to, you're more than welcome to use that YouTube link to watch the whole video. I thought that was very helpful to me within this presentation. Management treatment. Most common management would be to undergo surgery, pre-surgery, immediately after the injury. It's probably best to ice and splint the finger to prevent further damage. And NSAIDs are also useful in pain reduction. And surgery, without a fracture, the surgeon will actually just do a direct reattachment and repair of the tendon. With a fracture, it gets a little more complicated with bony avulsions, and the surgeon will do an internal fixation, which is like springs or screws or whatever they need to put in there. As far as treating this, early treatment is very important as it can restore blood supply to the finger. And surgery, like I said, is most common. Obviously, you'd want to refer this person to the orthopedic or the doctor to get an x-ray or a radiograph to ensure that this tendon is ruptured, and surgery will be required. Immobilization, we would put this athlete in a finger splint. Mallet finger, on the other hand, is an extensor tendon avulsion. So, as we see here on the image on your right, the extensor tendon is ruptured, which is the appearance of a mallet, hence why it's called mallet finger. The common mechanism is, as you see in the image on the bottom right here, with a flexed finger. The athlete is trying to catch the ball and just misses the palm, and then this force actually ruptures that extensor tendon. And some people tend to call this as jamming their finger. Pain and edema in the dip of the affected finger is common. There will also be a lack of dip extension as, like I said, the extensor tendon on the right here is ruptured, so the flexor tendon is going to pull it in flexion. Sometimes there will be a blood under the fingernail, or the finger will be detached from the nail bed. It's supposed to be attached, but sometimes it can detach. And there will also be tenderness at the site of the rupture. Being a baseball player or any ball player is a predisposing factor, as the common mechanism for this is trying to catch a ball. Also, previous extensor tendon injury or surgery is common. Special test, the only one I really had was the mallet finger test. I couldn't really find any good videos on this. It's very simple. You just have the athlete actively spread their hand, extending all the digits that they can, and when they do that, you'll notice that there's a visual deformity as the affected dip is stuck in flexion. Management and treatment, non-operative management would be 24/7 dip extension splinting for 8 to 10 weeks in hopes that the tendon will grow back itself. Police is necessary for pain and swelling. If there is no fracture to this or no suspected fracture, the distal phalanx is immediately splinted and extension for 6 to 8 weeks. On the surgical side, which is probably the more common, obviously they'll need to reconstruct the tendon. This will definitely be needed if there's a presence of a subluxation or avulsion fracture that is more than 50%. Treatment is obviously ice after the injury and elevate the fingers toward the ceiling, and it'll be necessary to refer to reduce the risk of permanent damage to the finger. And obviously we'd still want to refer to the orthopedic or the physician to get an x-ray or radiograph, or refer over to surgery. Immobilization, as we have at the bottom right here, a mallet finger splint, which will be necessary in order to immobilize the dip joint in extension, in hopes that the extensor tendon will grow back itself. Boutonerrie Deformity, this is actually French for Buttonhole Deformity. I know that's kind of a funny word. With the image on your top right here, that central slip is important. It's the part of the tendon that attaches to the middle phalanx. Bottom right, you'll see that's exactly what Boutonerrie Deformity looks like. The pip is actually stuck in flexion, while the dip is stuck in hyperextension. See, mechanism of injury is, like I said before, people call it a jammed finger. This is very common to a direct blow to the dorsal side of a flexed pip. Also, sometimes a cut on the finger can sever the actual central slip tendon from its bony attachment on the middle phalanx. And another mechanism would be just general volar plate contracture or tightness or tenderness. Signs and symptoms, obviously, since the pip is stuck in flexion, it cannot extend, and since the dip is stuck in hyperextension, it can't flex. There will be severe pain with this, and severe pain with any attempt to undergo range of motion, and there could be edema and tenderness and swelling. Predisposing factors, athletes that play contact sports or involve catching a ball. Rheumatoid arthritis is also a predisposing factor, as well as Dupuytren's contracture. It is just a chronic hand deformity that pulls the phalangeal joints into flexion. A lot of people blame video games for this, as people are walking around with their joints in flexion. I did have a couple special tests. I'll go ahead and give you a look at the Boutonerrie Deformity test, also known as Elson's, and the volar plate stress test. That can be used in boutonniere finger, but I'm not going to cover it because there's also a volar plate avulsion presentation that Tyler is doing, so he will be able to give you feedback on that. Again, you can also watch that whole video on your own time. I thought that was very helpful with me and putting together this presentation. Management and treatment. Non-surgical management would be cold application followed by splinting the pip and extension. It is important that it is splinted in extension, because if it's inadequately splinted, this deformity can be permanent. Splint at the pip will be necessary to straighten the finger, as it keeps the tendon from separating, so hopefully it can heal. Surgical approach would be developed from rheumatoid arthritis. The tendon is fully ruptured and won't heal by itself. And it'll be necessary if this deformity doesn't improve by splinting. Treatment would be a splint for 3 to 6 weeks, depending on age and the severity. NSAID steroid injections are necessary. Strength and flexibility exercises may be needed to pull the finger back in place, hopefully that it's not fully ruptured. Protective splinting or taping will be necessary if the athlete continues in the sport. And it is important that we at least treat this, whether it's non-surgical or surgical, as soon as possible, as the longer the treatment is delayed, the more likely it is to have permanent damage. Referral to an orthopedic, just like always, maybe even a physical therapist to work on strengthening and elasticity of the joint, and an immobilization would be finger splint at the pip. Swan Neck Deformity, just the opposite. Swan Neck Deformity is extension of the pip, and the dip is stuck in flexion. As you can see on the bottom right is a good image that I saw for a differential diagnosis between the two. Like I said, they're just opposite. Swan Neck is a hyperextended pip, and a dip that is stuck in flexion. 4 types. Type 1, pip joint is flexible in all positions of the metacarpal joint. And type 2, the pip joint flexion is limited in certain positions of the MCP joint. Type 3, the pip joint is limited irrespective of the position of the MCP joint. And type 4, pip joints are stiff and have a poor radiographic appearance. Rheumatoid arthritis is the most common cause of swan neck. There are also multiple others, but rheumatoid arthritis is the main one. Here we got untreated injuries such as mallet finger or a poorly healed fracture, nerve damage, loose volar plates, tight hand muscles due to an underlying injury, or Ehlers-Danlos syndrome, which is a hereditary rare disease that attacks the connective tissues. Signs and symptoms: since the proximal interphalangeal joint is stuck in hyperextension, it cannot flex, and since the dip can't extend because it is stuck in flexion. Earlier signs would be pain with pip flexion if this deformity is not developed fully yet. Rheumatoid arthritis is obviously a predisposing factor. Also age, cerebral palsy, Parkinson's, scleroderma, stroke, and trauma to the hand. Like I said, this is more common with rheumatoid arthritis. Special test, the only one I could really find on this was the volar plate stress. As I mentioned before, this will be in Tyler's presentation, so you'll need to refer to that. Non-operative management would involve restoring flexibility to the pip, and fixing the pip should fix the dip. If not, then surgery will be required in this case. And surgical approaches to this would be, like I said, if the dip isn't fixed, with fixing the pip, and if there's a progressive deformity, or any other issues. Surgical approaches would be soft tissue manipulation or fixation. Sometimes they'll also fuse the phalanges together that way, so there's not as much of a deformity. And arthroplasty would be another surgical approach. Treatment would involve passive stretching or progressive extension splitting for the dip, and obviously we'll need a finger split for this. Referral to the orthopedic again, and immobilization. A good splint would be a double ring splint to prevent hyperextension of the pip, as you can see with the image of your bottom right. And the last that I have is Pseudo boutonniere deformity. It is a boutonniere-like deformity, buttonhole-like deformity, very similar. The central slip of the extensor tendon actually does remain intact on the middle phalanx. It's not necessarily ruptured at this point. There are still some tearing of volar tissues. A really big difference with true boutonniere deformity is that, well, for one, the extensor tendon is still remain intact of the middle phalanx, but you can also tell this by passively flexing the dip with the pip extended, because if we actually did have a true tear, then the dip would not passively be flexible. Like I said, if that's confusing at all, I do have a differential diagnosis slide at the end of this presentation, which you can refer to as well. Mechanism is a result of an untreated hyperextension injury or any other previous injuries. It can also have the same mechanism as true boutonniere deformity. Pip joint does appear in a flexion contracture, tightness, tenderness, pain, loss of range of motion, and the dip does remain in extension. Collision and contact sports, participation in those can be a predisposing factor, as well as age. or also a history of boutonniere deformity, mallet finger, or other extensor tendon injuries or surgeries. Special tests, same as boutonniere deformity, Ellison's test and volar plate stress test, which you can refer to Tyler's presentation. Non-surgical management would be if the flexor contracture of the PIP is less than 40 degrees, conservative treatment can be approached, which in this case would be passive and active range of motion exercises or mobilization, police, analgesics. You definitely want to get that range of motion back, and a splint might be necessary. And a surgical approach would be necessary if the contracture is more severe. You'll still want to refer to the orthopedic and immobilization. Since this isn't a true boutonniere deformity or a true rupture, we can get away with a splint, also a dynamic splint, because we want to work on exercises as well. But we do want to make sure that that tendon is fully grown back. And differential diagnosis, we had minor sprains, phalangeal fractures, or arthritis. Keep in mind that mallet finger and jersey finger are primarily opposites, as well as swan neck and boutonniere deformity, as you can see with the images on your right. Those are good pictures that I saw for differential diagnosis. Also be mindful that boutonniere deformity and pseudo boutonniere deformity are different as well. As pseudo boutonniere deformity, the tendon is not fully ruptured. And I also have a YouTube video which was shown on my boutonniere deformity test that had a lot of useful information, which really helped me put together this presentation. You can click the link if you want to see my PCOT analysis. It was quite long. I didn't want to spend like 2 or 3 slides on just copying and pasting, so I just broke it down and summarized it. Population was 278 that were, quote, mainly adults with 283 mallet fingers. The intervention was to examine the effectiveness of different kind of mallet splints. And the comparison was multiple kinds of splints. I just listed a few: standard stack splint, custom splint, aluminum alloy malleable splint, a bonus splint, and plenty more. Those are just a few that stuck out to me. The outcome was that there was actually no sufficient evidence that one was better than the other, and there was no specific time frame given for the study. And here are my references. Any questions, please leave a comment.